Okay, welcome to the afternoon sessions. Our next keynote speaker is Jeff Bulte from Johns Hopkins University, and he'll talk about molecular and cellular MPI, how to deliver the tracer. Please give a round of applause for him.
Good afternoon. It's a pleasure to be here, and thank you for the organizing committee that asked me to speak here. This is my second time in Istanbul, and it's getting better every 10 years. I will talk about molecular and cellular MPI. And, sir, can you turn off these lights on the front? It's possible? It's very bright. So what I'd like to do is tell you a personal opinion about some of the applications I think are possible with MPI, and how we can learn from other techniques, mostly MRI, what the applications could be using these tracers and the field. So there are several non-invasive molecular and cellular imaging techniques that can be used to look at biological processes. They're all listed here. MRI, as we are more familiar with, is one of the key techniques these days for anatomical and clinical imaging. It has a very high resolution, great penetration depth, and it's used widely these days for molecular cellular imaging. At the bottom, we have MPI, a quick comparison between MRI and MPI because they're often named at the same time. So a plus here doesn't mean it's good, actually it's poor. So that's just the scale. I think the resolution of MPI as compared to some of the other techniques relatively is not that great, I think. Of course it has a whole body depth penetration. The sensitivity of cell detection, theoretically, it can be high. From what I've seen, it has not reached the sensitivity of MRI, for instance. It's possible to do longitudinal studies, and these, of course, are still experimental. So the first meeting in Lübeck in 2010, and we saw this morning in the plenary talk of Dr. Heiner von Brucker, that certain things take a while. So with MRI, it took maybe about 10 years from the inception, 1973, to about 1982, when the clinical scanners became developed. And it's interesting, back in the time, as there are now some controversies on what gradient strength to use, what is the best dry field for MPI, etc. That the development of clinical MRI around 1982 also went against conventional wisdom, whereas it was believed that low field scanners were the future of clinical MRI, and it turned out not to be the case. It turned to be 1.5 Tesla and higher. And as you know, with MRI over here. So what I want to give you is a sort of personal story of some of the work we have been doing and others have been doing, going from MRI towards MPI. And I list here proton MRI because I will also talk significantly about fluorine MRI, which has some of, I think, a great similarity with MPI in terms of the applications. So in Lübeck, so about 5 years ago, I gave a lecture of what can you learn from MRI, and I think the same principle applies, and there will be a lot of updates, as you can see. Some of the people you may not know or not remember, they were very early on at Philips, Hans Aerts and Hans Bulte, who have now moved on to other projects, Dennis Markov, and Michael Kuhn, who recently retired, and Jürgen Weizsäcker, who left Philips some time ago. And when we talk about a contrast or tracers, I think we now have with MPI perhaps multiple colors, which to me is very appealing when we can possibly looking at different cell populations or biological processes at the same time. MRI is very versatile. There have been many techniques to create contrast with MRI, and they're shown here. Now, what is relevant for this talk, of course, are the magnetic particles that are used for providing contrast with MRI, where we get this hyperintensity. We can always give cells positive contrast, gadolinium, which turns them bright. And a relatively new technique is chemical exchange saturation transfer, where you can saturate certain protons and give a reduction in contrast. And we have fluorine labeled cells. So the difference is we all detect protons here, which are tuned to the water molecule. So we detect the protons of the water molecule as signal, whereas here, fluorine we detect that directly as a hotspot. Now, I heard this morning somebody saying MPI contrast agents as compared to MRI contrast agents. Well, with MPI there is no contrast because there's no signal without a particle, so contrast is always something relative to relative. So they're really tracers, and I think we should clearly realize that that's a key difference, which also can be a key advantage. So for applications, I think we can learn a lot from nuclear medicine, studies people have done there, labeling cells, tracking cells. For molecular imaging, the pharmacokinetics and the pharmacology of these radio tracers is quite different than the MPI tracers. So I think although it is in principle a similar technique, the properties of the molecules that we're using will be quite different. So the question remains if that's feasible. On the contrary, I think fluorine imaging and MPI share a lot of things in common. First of all, they're both hotspots. They're both tracers. There's no background. We only have fluorine in our teeth, in our body, which is immobilized. So there's no background signal. Furthermore, fluorine is completely biocompatible. Why is it biocompatible? Because it's incompatible with any kind of biological reaction. So what I mean is it's totally safe. With the magnetic particles, I think with the iron, we're in pretty good shape if we have very low amounts. Now, what I think, and that's another, I think, topic of the future, if we want to have anatomical co-localization, we need to have another technique, be it CT of MRI, and so I'll talk about repositioning of animals. Probably at high resolution, it will be very difficult to use both separately, although image co-registration process is possible, but eventually perhaps that one machine can be used, that is something in the future, but they're both hotspots, and in particular, why they're similar, because they both use nanoparticles. So for perfluorocarbons, often people use emulsions, which are really nanoparticles in the order of several hundred nanometers, similar as the magnetic particles. So in theory, the pharmacokinetic modeling and limitations will be the same. And I predict that the first cellular molecular MPI studies will be very similar to those that we have seen with the early fluorine studies. So fluorine MRI is very old. It is in fact from 1977, so it was only 4 years after proton MRI was introduced by Laudeboer, Demadian, and Mansfield. And this paper is, I think, long forgotten, but they say a couple of interesting things in this paper, is that when you have a coil and you do normal anatomical proton MRI, the gyromagnetic ratio of the fluorine is very close to the proton, so you can tune the coil to the fluorine frequency and use that same coil to get the anatomical MRI and the fluorine MRI hotspot, so that's perfect. There cannot be more perfect co-registration of that. So that was mentioned. The other thing was mentioned, this was 1977. There were no clinical MRI scanners. But they already said one of the most difficult problems we have encountered in imaging animals, talking proton MRI, is interpreted complex proton images and relating the images. So this is exactly the problem we still have with MRI. If you use these magnetic nanoparticles, we get black holes, we get black spots, and there can be a lot of other sources of those black spots. Blood, hemorrhage, susceptibility artifacts. People have turned dark contrast of particles into bright contrast. I don't know where that has been going. I haven't seen any real advantages of application. So this was already mentioned that, and at the same time they called it a tracer molecule. And you can see here the first images. It's almost like an X-ray or a phantom for fiducial markers or something. Now, in about about 25 years later, the field of fluorine has really taken off, and I will show some examples of these applications that apply to MRI. Now, in comparison with iron oxide and fluorine labeling, one of the primary disadvantages is a very low sensitivity. The minimum number of cells that can be detected with fluorine MRI is about 10,000 or so. It depends on the depth, if you use a surface coil or a volume coil. But both have been now in clinical trials. Now, there are two ways of labeling cells. I'll give examples from both. One is to add the tracer, the fluorine or magnetic particles that can be for MRI or MPI. This could be an MPI scanner. To add that to the petri dish. Then the cells take it up, and you inject the cells in image that, and you see the localization of these cells. So it's called ex vivo or pre-labeling. And it's kind of interesting, what goes around comes around. Stefan Molteni Biotech is now in the process of making particles that may be used for MPI. They have a large clinical experience with magnetic cell sorting, and this is one of the earliest papers where cells were labeled with Stefan Molteni, who was involved with this. One of the earliest studies, I think, back in the Netherlands, and performed around 1990. And you can see here these particles bound to the surface of the cell. And one of the goals was to get it inside cells. And you can see here, when we label cells with our MPI tracers, we'll get very similar results. What you get is that they get taken up by endosomes that fuse with lysosomes into lysosomes. And you can see here the fusion of the lysosome with that vesicle, and the particles are then digested. So back then there was a lot of interest in immune cell labeling because immunotherapy evolves. Currently there's a lot of interest in stem cell tracking. Why is that? Well, there's a lot of money to be gained from that, especially when you live in California. So here's an example of labeled cells with different echo times. They all have the same concentration, and if you increase the echo time, you can make them completely disappear, so they turn hypointense. Now here's an example of that tuning of that coil. So we can obtain a proton image that is anatomical, then we obtain the fluorine and the hotspot imaging. And you can see the resolution of fluorine is not that great, but if you know exactly where you're looking at on the anatomical images, you're fine. So California Institute of Regenerative Medicine is a huge funding agency. I heard now they have a 10-year, $10 billion plan. Are you ready? They want to have $100 billion for 10 years. Unbelievable. They're lobbying for that. Now, we have a very small program in Maryland that's called the Maryland Stem Cell Research Foundation. So we're talking about $12 million a year, and there are like 200 scientists who want to have a piece of that. But that is now currently funding a clinical study, hotspot MRI of human adipose-derived stem cells for liposuction. We label that and give that back to women who have had breast cancer. The breast is removed, they have radiation therapy, and then you can get fibrosis and scarring, and the stem cells can heal the tissue, they can make new skin and new blood, and there's very little known about the survival and persistence of these cells, so we try to image them, and we are currently having 6 patients in this study. Now the second method of labeling cells is so-called in situ. So cells are not labeled, but the particles are injected, and then in the body they're taken up by macrophages and other cells. And this was the earliest application of magnetic nanoparticles in MRI. There was a company in Boston, Cambridge, who was already developing magnetic kits for imaging, not imaging, but sensing molecules. So there's sort of a magnetic ELISA with particles attached to a polystyrene coat that could capture things, and they made a similar particle. The particles were originally developed as a liver agent. So in the liver, we have so-called Kupffer cells, which are macrophages or scavenger cells. And this is one of the earliest images of using Faradex, which is no longer made. It was economically not viable. It's not because of safety concerns, as the patents expired. And the other thing is MRI just got too good to detect liver cancer without contrast agents. But here's a liver of a patient with a lot of metastasis. So this is the normal liver tissue, because the Kupffer cells take up the particles and it becomes black. But this is all displaced. We have here dysplasia of the tumor, so there are no macrophages in the tumor, so it does not turn black. Now, a variation on that was to make smaller particles that circulate longer, and they are taken up by macrophages in the lymph node systemically, and this is the normal scenario. The lymph node here turns black. This is a normal lymph node, but if there is a metastasis, dysplasia, in this case prostate cancer that has metastasized, you can see that it does not turn black, which is great to know if you're a urologic surgeon, because you want to know really which ones you have to take out. There are a lot of nerves, and you want to spare, of course, all the function over there. So this could be very useful. It never got FDA approved though, so that's that story. Now, there are also macrophages with autoimmune diseases, for instance multiple sclerosis, where you can see uptake of particles in lesions here, small particles here. You can make them positive on the T1 weighted image, and here they give a typical hyperintensity. Now, this is a more recent study, and I think this can be done with MPI as well, or even better, because I think MPI is good for quantification. And what is done here, magnetic nanoparticles are taken up by inflammatory cells in the pancreas. So the pancreas turns dark, and you can measure the relaxation times. So with MPI you can measure all sorts of things and express that linearly. So here's a normal patient here. You can see here the colors of the pancreas, so they have very low relaxation. But when they're inflamed in type 1 diabetes, you can see here quite a different pattern of uptake. You can see the hotspots here of these uptakes. And it's currently in type 1 diabetes, it's very hard to manage these patients and give drug regimens and see how effective they are. So this is a very good way of imaging inflammation. Now, my group, I want to show you an example of the practicality of this. This has not been published yet. It's well known clinically that people with inflammatory bowel disease, IBD, they have to get a colonoscopy once a year, maybe 2 times a year, to see how much it is inflamed. And it's not known what causes it, in fact, but if it's severely inflamed, unfortunately, most physicians advise to take out that part of the colon and to lead it to the front to make an artificial an orifice, because the risk of developing colon cancer is so high that it's not smart to leave it in. So we have done a study to see if in inflammatory bowel disease, if those spots that are hot with fluorine, those would be spots that are hot with MPI, with the magnetic nanoparticles, if they develop into cancer. Now I want to show you here an image, a fluorine image that is obtained here. Here's the proton image. Now you can clearly see the localization here of these hotspots, and we're looking here in yellow here at the colon. So this is the colon. Now I think you can agree with me that if you do this with iron oxide particles, you do normal proton MRI, but you would be unable to see where the particles are located, because this is already there, right? And it even looks like this. This is purely some air in the cone, and so this is a great way to take advantage of unique properties of these particles. And you can see when you look at the histology and you look at these hotspots of inflammation in the colon, you can see, and this is earlier that later on histology, these areas of cancer develop at those places. And in fact, more and more in general medicine, including at all sorts of cancer, there's a very direct link between developing inflammation and cancer. Often in several types of cancer, for instance, lung cancer often starts out with irritation, inflammation, and then cancer develops. But when you quantify the fluorine, and I forgot to mention that the other similarity between MPI and fluorine is that the tracer is, the signal is linearly dependent on the tracer amount. So the quantification is very straightforward. With MRI and magnetic particles, we cannot quantify the number of particles, although some people claim they can. It's not being used. It's really not useful. So we can see here in the dysplasia area how much fluorine there is, the ratio. We can see that here. This is no dysplasia, which corresponds to the pathological colitis score. Now, going back to the iron oxide story for cell tracking, as of today, there have been 9 clinical studies performed in the world. It reminds me of that MPI roadmap I saw this morning with the number of presentations in countries. But the only thing is, there's no study done in Germany, so that's quite a contrast, and most of the studies have been actually in Europe, nothing in the US. And so one of the issues is that these clinical formulations have been discontinued, that Ferredex and the Enduran. So it's hard to do clinical cell tracking of iron oxide. Now, I will show you the real application of MRI cell tracking with MRI is the delivery. It's the immediate delivery real time with MR guidance. So that's not possible with fluorine because you need the anatomical image. With MPI, it would also not be possible because you do not know exactly where you are, and I'll show you what I mean. Okay, so the idea is here. There's a cancer vaccine, so these are dendritic cells that educate our immune system to fight cancer, for instance. So these labeled cells need to be injected in the lymph nodes, and this went wrong in half the patients. You can see here the magnetic particles in the cells are in the fat, so they missed the nodes. Now they didn't know that the radiologist did such a bad job. They used ultrasound to look at the needle. But so before they did nuclear medicine, they did indium, which is shown here. So what you did, and you can see this hotspot of your indium labeled cells. So if you do this with MPI, I think we would see something like this, but it doesn't mean it went okay because it could have been injected there. So these kind of clinical scenarios will need to be thought about what the real applications are. Here's another example of a surprise, I would say. This study was published last year, a study performed in Poland. There were some people in my group, and there was a child who got hypoxia during a surgery and remained in vegetative state. The parents had frozen umbilical cord blood cells at the time of birth, and they assigned consent to use this as an experimental therapy for neural stem cell therapy in the brain. So these cells were labeled with Ferredex and injected in the ventricle of the child, in the occipital horn, because the idea is that you can reach the entire brain by the ventricular CSF flow. There's our brain, just like the Bosphorus, it flows, it's not stagnant, it just circulates everything. And that was the thought. But if you can see here, cells are red here, that you stay in that horn that they are injected in and they do not move. And the particles didn't make them heavier. We did sedimentation studies. So apparently, so the patient is in a vegetative state and always lays on one side. So if you want to do effective therapy, you would have to move the patient around, that the cells can go everywhere. And I think these are typical scenarios that you do not think of with these new therapies, that this is so trivial, you just don't think of it to move the patient around, just like a test tube almost, even though how crude it sounds. But so I think we will have a lot of surprises with that. So I want to make a statement, MRI versus MPI, so first MRI. So I think the number one clinical application of MRI cell tracking may not be monitoring cell migration following injection, because everybody wants to look at cell migration, but too many problems, cells die, macrophages take it up, cells divide, so the label dilutes. But it's rather verifying the actual accuracy of the cell injection itself at the target site, and then in real time using MR-guided injectional procedures. So that cancer vaccine study I showed you, where the missile lymph node performed in the Netherlands, was the first clinical cell training study. It was performed using ultrasound guidance. If you use MR guidance, they were not set up to do that, and you make a mistake, you're injecting the fat. You can see that in real time. So you give a second injection, and that, I think, is the clinical application. Now for MPI, that will not be the case, because we don't have the anatomy. So I think the number one clinical application, MPI cell tracking, may not be verifying the actual accuracy of the cell injection itself at the target site and then in real time, but to determine whole body distribution. And that is something that MRI cannot do. It's impossible to look at the whole body distribution with these tracers. With MPI, just like nuclear medicine, you would have that, that whole capability. So I think that is one of the things. Now, in the future, maybe MPI or MRI can be combined to look at dynamic processes. We have seen blood flow previously in movies, superimposed on MRI, and perhaps we can do something like this that I will show in a moment to movies. So, in cell therapy, patients have stroke. There have been some clinical studies performed by injected cells in the carotid artery. And it's very dangerous, because these cells, if they clog up blood vessels in the brain, they will even cause more strokes. And this is a significant concern, and there's very little known about the dynamics of the inflow. So we have compared two different cell types, glial restricted precursor cells, 50 micrometer, mesenchymal stem cells, 25. And I can show you the differences in the inflow and outflow. So here, the small cells on the left, and here are the big cells on the right. You can see them here going in, and they're moving through, whereas here you get the filling and the cells remain there. And each frame is 10 milliseconds, so that's the temporal resolution. So if you want to do this more sensitive, maybe we can look at the inflow with MPI. We're not talking blood, we're actually talking labeled cells, and then superimpose that, for instance, on the MRI. Now, talking about blood flow and perfusion angiography, MPI angiography, and MR angiography, we look at cerebral perfusion in the brains of dogs with ferraheme, which is also an iron oxide particle, but it's very small. It's called the USPIO. It's a clinical product. It's used for treating anemia. And when you give a perfusion, it clears. So there's a bolus in this perfusion. So what did we do? We took advantage of that to look at the vessel patency. So when we inject our cells, do the vessels clog up? Is the perfusion compromised? So we can inject a bolus here, so the signal intensity goes down, clears up, second bolus, third bolus, and you can see that the signal at the end is the same as in the beginning. With other words, the particles completely clear out of its circulation. So that's a good scenario. Now we inject the labeled cells. They will accumulate. This is in the dog over time here in the brain. And the question is this bad? I mean, is the cerebral perfusion compromised or not, and how bad is it? So then what we can do, so now we go here to the baseline, so we ended up here at 500, right? So We start here, and now we give a bolus of the therapy, and we look at the clears, and you can see that the bolus completely passes and clears. So even though this is all dark from the cells, we conclude the perfusion is not compromised. So the ending question that I have, what I have shown you here, will all this be relevant to the development of a clinical MPI scanner? And the question is, what is the need? What will it add that the other imaging techniques cannot do? Is it angiography? Is it cell tracking? Is it detecting cancer? All sorts of issues from kinetic problems with the particles, the production of the particles, the cost, and how is MPI angiography competing with existing angiography? MRI angiography is these days very sophisticated. So the question is all this relevant for clinical development? I just have one thing on my MPI wish list, which is this: an MPI microscope is all that I'm asking for, and I think I will use it preclinically for some of the applications. So, thank you for your attention. Any questions? I'm sorry I didn't show that much MPI data. I've been wanting to do MPI for 10 years. And I started out in 2005 with Shaq Dickerson, with older people, and it has been a slow process overall, but I think maybe that's a good thing. So it's very thoughtful what everybody's doing and how it all is being developed. I think it's a very good thing. MRI took a very long time, so I don't think there's nothing bad with this. Okay.